Welcome to AUA Leadership in Business, an official podcast of the American Urological Association. This episode is brought to you by the AUA Policy and Advocacy Resident Work Group and was originally presented as a virtual event.
Well, I was going to introduce Dr. Ruchika Talwar, who's here with us today for our first fireside chat of this year. I don't want to kind of give too much away because she's going to be talking to us about her career path and how she's ended up where she is, but I'll say that she did residency where I am currently, UPenn, so I'm very proud to say that. And while she was a resident, was actually one of the founding members of what we now call the PAR. So she has deep roots in this group and I think can be a great example for all of us. And she is now one of the oncology attendings at Vanderbilt. And she has a really cool appointment where she's doing a lot of strong health policy and advocacy work. So that's what she's going to be talking about with us tonight.
Yeah, thank you so much, Kara. I really appreciate the invitation to talk to this group. As Kara said, I am a huge advocate of the PAR because it did so much for me during my time as a resident and really helped connect me with the world of AUA policy and advocacy. So it's a pleasure to be chatting with this group tonight. Kara, are you able to see my slide?
Yeah, it looks perfect.
Perfect. Okay, great. I will kick things off formally, but I just want everyone to know that this is, very casual. And so if you have any questions at any point in time, you can raise your hand, you can, throw your question in the chat and I'll ask Kara to help me out and monitor that while we're going. I am totally fine with stopping, discussing, going into more detail about something I say. It's very conversational. But I'm really excited to kick things off. So this fireside chat was called Designing Your Dual Path, a Career in Urology and Health Policy. But as I'll get to later, I think it's not quite a dual path. I think there's actually quite a multi-dimensional view of making a lot of this work part of your day-to-day career. So the name is just a little bit of a misnomer there. I have some disclosures, I guess, none financial related to this talk, but as Kara mentioned, I'm finishing up my fellowship at Vandy and staying on faculty in a really unique role, which we'll get into. And all of this content is really geared towards trainees who are looking to prepare for a career that leverages the clinical experience that you've had throughout your training and in practice as a urologist, as a subject matter expert to help shape the way our healthcare system functions. I'm not somebody who has the wisdom from working years in a role or making my way up the leadership ladder. This is definitely a trainee focused talk, but I hope that my journey can help all of you realize that there really is a way to incorporate non-clinical healthcare related passions into a career in urology. And, that could be health policy, quality improvement, value-based care. It really, really spans many areas here. So I alluded to this earlier, this title is called The Dual Path. You think of something that you're doing in parallel. Oh, I'm a urologist, and in parallel to that, I'm doing all this health policy work. But that's not really how it works. The way I like to think about all of this is that I have several interests and several passions. They're like puzzle pieces, but it's my job to figure out how they all fit together to create, a career that lets me accomplish all of the things that I want to accomplish. But first, I'll share a bit about myself. I went to medical school in New Jersey at Rutgers, and I did my undergrad there as well. And I really had an interest in health policy way back when. I knew I wanted to do a pre-med track, but I pursued legal studies also. I actually, before deciding on medical school, once upon a time thought I wanted to be a politician. And then I met New Jersey's finest politicians and I was like, not my vibe. This is not, I don't fit in here. I don't see myself doing this. And so pivoted a bit towards healthcare, but that passion for systems level change and being engaged in the legislative process really never left me. And the way I was able to manifest that in medical school was through organized medicine. I was involved with the American Medical Association from the get-go, rose up the ranks in AMA leadership throughout my time in medical school, and eventually decided on a career in urology. And during urology residency, my interests continued. I stayed as the AMA, the resident and fellow delegate for urology to the AMA. So I was a voting member. But I started thinking more broadly outside of just advocacy and the AMA. I started thinking about how we can improve the systems in which we work. My time as a resident, I became very focused on areas for improvement, targeting QI, and I had an interest in urologic oncology that I identified. So I started thinking about cancer care. How do we deliver cancer care? What kind of research can I do that perhaps is focused more on the cost of care, healthcare delivery, healthcare quality, as opposed to the traditional, lab related urologic oncology research. And I came to Vanderbilt to do my urologic oncology fellowship, as I referenced before. Really, I feel very lucky to be in a place where, although they are a bit more research focused historically, some of the onc faculty here have, big outcome studies. I have a mentor here who is very engaged in healthcare delivery, but more importantly, I had the freedom, to explore my interest in drug costs and a lot of these other areas that people maybe didn't have direct expertise. But I was able to leverage the resources at the university to try to help bridge some connections there. But like Kara mentioned, clinically, 50% of my time at Vanderbilt is spent as a urologic oncologist. So what that means is I have 1 day of clinic where I see patients, 1 full day of block time in the main OR. And every other Friday, I alternate between protected time in population health and a day at the surgery center. So it really comes out to exactly 0.5 FTE. And you might ask, what are you doing with the other 50% of your time? So that's fully paid for by population health. And the reason I stress fully paid for means I don't need to be getting grant support. I don't need anyone else buying out my RVUs based on funding, external funding. It's supported by the health system. And my role is as an associate medical director in the episodes of care office. What that office does is it designs and operationalizes Vanderbilt's bundles program. These bundles products are direct to employer services that provides essentially a single predictable price of an entire episode of care, as opposed to paying for healthcare fee for service. I'll give you an example that we're all familiar with: kidney stones. If a patient is seen in our ER or in the office with a kidney stone, and they have employer-sponsored health insurance that participates in this program, we'll enroll them in this bundles program. The employer pays for the cost of the entire episode, which in most cases is 90 days. That'll vary based on the situation. But for 90 days, we provide all of the care at one single predictable cost. So whether they have 3 CAT scans, whether they have no CAT scans, whether they have 10 CAT scans, that price doesn't change. The best part about this for the patient, and what excites me about this program, is there is no out-of-pocket cost to patients, 0 out-of-pocket costs. And we are able to share our cost savings with the employer. So everyone has skin in the game. If we save money, we win. If we save money, the employer wins. It's a really great way to provide high quality shared savings for all parties involved. Every patient has a dedicated patient navigator. We really focus on the patient experience. And that's the program in a nutshell. It excites me because it's pushing the boundaries on how we deliver care. We're cutting insurance companies out of the picture. We're getting rid of a lot of these, inefficiencies and extra costs. But it also is physician-led, which is important to me because, I'll reference this throughout the talk, but I think historically, the reason healthcare is the way it is, it's because physicians weren't as engaged in some of these really important, design-related aspects when we think about how did we figure out how we're going to pay for healthcare? Who made that decision? I could tell you it wasn't a doctor. It wasn't a doctor that had the final say. They didn't want to do prior auths all day. So I think that we're heading somewhere really exciting here, and we're the first of our kind in academic medicine to be doing this. So that's a bit about me. Now, what are my objectives for this talk? I broke this down into 4 categories. We'll talk about clinical training, because that is the most important thing for a surgeon. We'll talk about where to focus your academic efforts if you're interested in a hybrid career, again, whether it's health policy, QI, some other aspect of healthcare delivery. We'll talk a bit about the importance of an elevator pitch, and I'll go into some detail about what a value proposition is and how you can prepare yourself to interview for whether it's a fellowship or a job, and make a case for why you should be given a title that is paid and supported by either your health system or your practice to do this work. So first and foremost, clinical training should and must be your number one priority in residency. And, I feel strongly about this for a few reasons. By investing yourself in strong clinical training, I think you really create flexibility for yourself, either in fellowship or in early career practice, because you've gotten a lot of your reps in. We all know it's not exactly the same as being out in independent practice, but you can at least ease some of that learning curve when you're out there alone. You just getting your numbers in, seeing as much as possible, getting exposed to, some of the mistakes that can happen, some of the errors that can happen, or some of the technical challenges that you'll face when you have a bit of a safety net with you, an attending there who may be able to bail you out. So that is first and foremost. But I will acknowledge that I remember often feeling sort of frustrated by the exhaustion and the hard work of the day-to-day, when I feel like it used to be like 3 a.m. and I'm like scoping in a catheter, and I'm like, oh my God, I'm dying. Like, I really want to do some, I have this health policy idea. I haven't had a chance to breathe to even like pursue this. And I'm here and I feel like it's like one task after another on the checklist. And I've just been pushing this like important priority of mine to the side. I want to take a minute to acknowledge that, because we all feel that. I felt it, after a long stretch of call, when you maybe didn't get to some of the things that you wanted to get to. It's easy to get frustrated. But that's why I think it's really important to have a community of people to lean on. And that's one of the things the PAR does. So I think finding your people is really important. There's a few folks here that I'll mention. Juan Andino, he's another young urologist who has a passion for health policy. And he and I did our residency interviews together. We connected at one of the summits when we were PGY2s in that photo. And I remember both of us, like, we were like, I told him, Juan, I was like, I have all these aspirations and I feel like I can barely keep my head above water. And he was like, I feel the same way. And it was so great to go to the summit, hear about all of the issues that we were so passionate about, firsthand advocate for those issues with our congressional representatives, but also be in a community of folks who understand the importance of the work. And likewise, Hans Aurora, who's in that second photo, has just been a friend, a mentor, a guide for me on this journey, throughout. And he has multiple roles with the AUA and the American Medical Association, but he's another person where I would, call for advice routinely, or just say, Hans, I feel like I've just been trying to focus on oncology research to match in fellowship, and I'm not being true to like what I actually want to do. What are your thoughts? And so make those connections at the PAR level. Go to the summit. I think it's one of the best things you can do to just show yourself what's out there in the community and meet like-minded folks. And the last picture is from Penn. Penn actually has this certificate program that Dr. Michael has done and others in our residency have done. It's called the quality. Actually, Dr. Michael, you might have to refresh my memory on it. It's like the QI track. There you go. Healthcare leadership. I was like, I'm missing something. There you go. Healthcare leadership and quality. We used to call it the quality track for short, so I feel like that's stuck. But it's healthcare leadership and quality, and it gave us exposure to how we pay for healthcare, how to conduct a QI project, different ways to structure care delivery models. You just had a whole, like, it was a 2 week, 2 weeks your PGY, or your first year. I did it in my PGY 3 year, and 2 weeks of didactics your PGY 4 year or the second year. And it just gave you a nice introduction to all of these things that you've never learned about the business side of medicine, how to conduct systems level change, quality and formal quality improvement training. And that group of folks, they were not in urology. They were residents from all over the health system. And it really opened my eyes because, again, we are so siloed in our subspecialties. It helped me put myself in other people's perspectives when I thought about, this system seems really inefficient. I wonder why the emergency room does it that way. And I had someone I could lean on to give me their, firsthand experience of what works in the ED and what doesn't. So I think, that experience was unique to where I did my residency at Penn. It didn't require any time off. It was built into the curriculum. So I encourage you all to think about what kind of programs might be available at your institutions. They're not going to be within urology. We don't have that yet, although I'll talk a bit about what I'm trying to build here at Vanderbilt. But, I turn to experts who are within the universities, maybe not even the health system, but within the universities that your hospitals are affiliated with. That will help. Or don't be afraid to cold email someone who's at an institution across town, even if it's not the same as yours. I think there's a lot of resources there if we know to look beyond just our specialty. So now let's talk about your academic focus. I crossed out the word research here, and that was very intentional. Traditional research does not need to be the only way to be academically productive, especially in this sort of health policy, healthcare delivery, QI work. Advocacy activities are important. Designing, improvement protocols are important. Serving on committees, for example, patient safety committees, that is a leadership role, and that should also be very valuable for someone who's interested in that type of work. So I use the umbrella term academic focus here. And be creative about the output of this work to get credit for it. You want it to be a line on your CV. So I really relied on this for some of the committees I worked on, for a lot of the advocacy work I do. Traditionally, we measure productivity by publications. You Google someone, you see how many articles they have on PubMed. That's not as important in the real world. Even for those of you who are going to go straight into practice, when you're approaching your hospital leadership saying, I'm interested in leading the hospital's, QI initiatives, they're not going to PubMed you. They're going to want to know, how many quality improvement projects have you led? What has been your exposure? How many hospital committees have you sat on? And so try to think about how those activities can help increase your exposure to this type of work. And instead of, for example, instead of a paper getting into, JAMA, think about the other ways you can have academic output. Consider writing like a short form article. We have the ability to do that in Journal of Urology through the JU Forum, an editorial on an important topic. It doesn't even need to be data you're presenting. It could be your viewpoint on something. And there's a lot of new ways to present posters that are outside of the specific research format at our annual meeting as well. There's an entire quality improvement area, and they're only continuing to expand this. There's educational focus sections where, you would be able to present a poster, be able to go to a meeting and show your program that there's value in what you're doing, even if it's outside what would be the traditional research that people have done in the past. And the reason I think having that output is important is because it's a win-win. Our programs want us to go out there and present because it gets their department logo on the big screen, and they want their department to be well represented and to look good. And you can do that in those types of ways. And you'll notice on this slide, I have, how does this contribute to your mission, vision, and values? And that's an important thing to think about. I think we've always been told that we need to say yes to everything. Although that is really important to some extent early in your career, there's only 24 hours in a day, and with limited time, you only have bandwidth to do so much. And I want to stress this: everything you all do academically needs to justify the job that you're going to be asking for in the future. And so when an opportunity arises or you have an idea to do something, ask yourself, I'm a PGY3 resident. I am still recovering from the PTSD of my 2-year. I might be planning a wedding. I may have children. I may have a family issue that I have to deal with on top of a really tough residency schedule. Is this something I'm going to be able to do well? And is this something I can handle? Is this something I can put on my plate right now? And if so, does it contribute to my mission, vision, and values? I just like to ask myself that question from time to time when I feel myself getting overwhelmed. So I think it's something important to bring up in this group, because eventually we all need to move away from the say yes to everything model. These are just some examples of how I was able to steer some of my academic work to tell my story. And this is how I was able to market myself when I was looking for jobs. And, I was able to market myself as an expert who would be appropriate to give an associate medical director title to in value-based care, right? Like I was a urology resident. Did I work, on Penn's bundles program? Of course not. But what made me qualified to do this? So although I was doing prostate cancer research, I tried to gear it towards quality assessment. So I really tried to focus on, how can I use this database we had locally called PERC? It was the Pennsylvania Urologic Regional Collaborative, modeled very similarly to music. How can I use this data set to publish on prostate cancer, but also how can I create sort of quality measures? I modeled these quality measures and saw how we were doing and said, well, why would this be relevant? Because one day if we move to a cancer value model, perhaps physician performance will be tied to these quality assessments. So you saw I took a prostate cancer clinical research project and I shifted the focus a bit. And I kind of told the story I wanted to tell with a health policy spin. Similarly, I had done some work in kidney stones, and it was assessments of patient-reported outcomes and quality of life. Now, those were really interesting studies. I learned a lot. How did that help me when I sat down and said, I'm looking for an associate medical director job to run, a bundles program? Well, I said, I'm actually published, and I've done a lot of work on validated ways to assess the patient experience. All of a sudden, the non-clinical person, says, oh, patient experience. That's a huge priority for the health system. They look at my CV, they see I've published 8 articles on this. Oh, okay, she's a subject matter expert. Absolutely. Similarly, post-op pain pathway. We had this whole opioid reduction protocol at Penn. And how does that help? Like that helps me get that with QI work, that was a quality improvement work project that we took all the way through. And so that gave me credibility on how to successfully implement and run QI. And similarly, I did some work in drug access, drug costs. Okay. Now I feel a lot more comfortable understanding how we work with our pharmacy to dispense medications for our bundles patients. So you'll see the common theme is there's a way to tie research that may not directly be health policy research into the work that you're interested in. It just takes a little effort. My background is in clinically is in urologic oncology, but as I just referenced, a lot of these projects are not just urologic oncology. So don't be afraid if you think I'm going to do general urology, I'm going to look for a job right after practice, or I'm going to do pediatric urology. That doesn't mean that prostate cancer research project can't have a good health policy spin for you, because it may not matter if someone's looking at how many pediatric urology publications you've published, but it will matter when you're trying to justify why you should get paid for a leadership role. Now, this is an important slide, so we'll spend some time here. And again, I just want to encourage, if anyone has any questions about anything I'm saying, please, type in the chat and we can dig in deeper. But we've all heard about the elevator pitch. In fact, we've probably all had an elevator pitch ready to go when we were applying for residency. And, once you start interviewing for either a fellowship or your first job, you're going to have to leverage all of that prior work that I just referenced to really market yourself as someone who has the experience to justify why they should pay you to do non-clinical work. And I stress that because really for a health system, your value is seeing patients, or actually more importantly, in the operating room, right? Because that's how you generate revenue. So if you want to do non-revenue generating work, there needs to be a value proposition there. And it's up to you. The onus is going to be on you to articulate what your vision is and why you're qualified for that work. And it's very, very important that you protect your time for this work. So you can't be hired as 100% clinical, 5 days a week patient care person and still do, for example, still run the hospital's quality improvement program. It's not possible. You can't do that work on nights and weekends. And frankly, if you're 100% clinical, that means you're 120% clinical, in that if you're seeing patients Monday through Friday, you can expect to spend some time on Saturday working on your Epic inbox, because again, there's just not enough hours in the day. So, you know, for an academic model, a lot of times they'll give you what's called 0.8 FTE. And what that means is 80% of your time is direct patient care. So that's 4 days a week of direct patient care. Now, again, when you're 80%, that's more like 100%. You can expect that last day to be spent, you know, oh, there's an emergent add-on case. I got to like clear out my inbox. I got to finish my notes. You know, there's a lot of stuff that's related to clinical care that's going to take up your time. So ideally, you can get yourself a 50% clinical role and have that other 50% paid for by the health system with another role. And that's what I described to you earlier when I told you all about the role that I'll be, jumping into. So that time becomes protected. Of course, I'm available if, God forbid, there's some kind of clinical emergency. And sometimes I have spillover as well, but at least that time is protected. And I stressed something earlier. I said, every other Friday, I have a Surgery Center day, and every other Friday, I'm Pop Health. The reason why I fought for that was because if you say you're going to be half a day, let's say I have half a day of block time in the Surgery Center in the morning, that is going to turn into one full day. There is no doubt about it, where I will add on more cases or things will get delayed, blah, 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 turnover is slow, whatnot. So I really fought to have the every other stagger so that I could protect that entire day and have it available for meetings, work, etc. In this elevator pitch, you need to articulate why you want to be, for example, the director of QI. What experience do you have to justify that? You want to be a value-based care leader? What have you done in the realm of value-based care? Maybe claims and payments, maybe some of those quality assessment research studies I referenced earlier. Practice the justification for the role that you would like to see yourself in. And this is going to change over time. So you'll notice on the slide where like the light bulb is getting brighter and brighter. My elevator pitch changed dramatically from, when I was a resident to what I pitched folks when I was applying to fellowship versus what I pitched folks even just a couple months ago. And it's going to continue to change because your exposure to things will change, your interests will change, and that's totally normal. But start thinking about what your end goal is, and you can help design all the other work to fit the elevator pitch, right? You can say, I'm interested in a project that will increase my exposure to costs of care, because eventually I want to fix how we pay for healthcare. That's one lofty goal, but this is the way to start thinking about things. And similarly, that elevator pitch is going to demonstrate your value proposition. And that is, what can I bring to the table? Why would you pay me to do non-revenue generating work? What is my expertise? What makes me qualified in this area? The one thing I'll stress here is the fact that you have an MD after your name, and the fact that you have worked in a health system, you completed residency training in a healthcare system, gives you so much more credibility than you realize. Especially lately, the way the healthcare system has been going, everyone knows we need more physician involvement, and they're actually eager. People are eager. Like, I live in Nashville. Right now in Nashville, we have the highest number of healthcare startups in the country. It's like the health tech hub of the country. They are so thirsty to have doctors on their advisory boards, to hire medical directors, to hire chief medical officers, because all of these ideas cannot be successful without clinical correlation, without knowing that this idea actually works in a broken healthcare system. You can't, you just can't know. For example, look at Walmart. Walmart just shut down their entire healthcare arm. Amazon clinics have been scaling back. They had huge plans. Amazon had huge plans to expand their Amazon Medical or Medical One or something. It was something like that. And they totally scaled back. We've seen that joint venture with Berkshire Hathaway fail. Healthcare is really hard. And a lot of that is because the people making the decisions don't actually know what it's like to see, a day of patients in clinic. Or they'll say to you, these private equity firms will say to you, like, well, you just got to fix your OR efficiency by 40%. There you go. You'll save $2 million. They don't know how difficult it is to actually mobilize all of the things that need to happen to safely get a patient in and out of the operating room. So you have a lot of expertise there. And I just want to give people confidence, because I don't think I fully realized that. I thought, I'm a brand new fellow. What can I bring to the table? As I said earlier in my disclosure for this talk, this is my first job. I haven't had, leadership roles in a healthcare system before. That does not matter. They need people who are dedicated to health policy and healthcare delivery type work. And so the fact that you're even willing to spend some of your time on this work gives you the leg up right off the bat. But you just need to make sure you have a strong value proposition. What experiences have you had in the past that make you qualified for this role? A couple things that I'll cover that I'm sure people are thinking, or maybe we'll ask later. I went back and forth a lot about this first question, and people ask it all the time. Do I need a degree? And if I need a degree, what degree? Dr. Michael's one of the few in the world who has a master's in health policy. That doesn't exist at most places. It's like, if you're interested in health policy, you're like, okay, do I get an MPH? Well, that's not really health policy. Do I get an MBA? That's not entirely what I want to do either. And so I would actually tell most people an extra degree is not a requirement. And I'm a little bit of a hypocrite because right now I'm getting a master's of management in healthcare. So I recognize that this is coming from someone who is getting an extra degree currently. But part of that was something I was able to push for when I signed my job to stay here. So, I think even if had I not stayed at Vanderbilt and had I not had the ability to do this master's of management in healthcare, I still think using all the other things I just discussed, I'd be able to still, market myself as an experienced person to have dedicated time to do some of the work I'm interested in. But the extra degree does help. I want to acknowledge that. And the other thing I want to acknowledge is the importance of networking that comes from doing those sorts of degrees. You're exposed to a lot of people who, again, are outside of your little silo of urology. And so even if, and actually I'd argue for my master's program right now, I'm with people who are totally non-clinical. There's people who work in medical billing. There's people who are in healthcare tech, and I learned so much from them because just as I feel they are clueless about clinical medicine, I am equally clueless about how, long it takes to bring a device from research to, fruition, for example. So there's always a lot to learn, and you want to keep an open mind. Although I just gave you all that confidence to say you have the doctorate degree, like you're an expert, you're always learning, and there's always more to learn because you can always put yourself in someone else's shoes. Now, the next question that we talk about, do I need a clinical fellowship? Can I do a non-clinical fellowship? And what I mean by non-clinical fellowship is there are certain health policy focused fellowships out there, such as the National Clinician Scholars Program, that people can do without doing an actual clinical fellowship. So they may not want to do urologic oncology or pediatric urology or endourology. They may say, I'm going to go do this National Clinician Scholars Program that's offered at a few universities around the country, and I'll actually work as a general urologist at that institution. There's folks who have done that. So again, there's no right or wrong answer here. I think you can be really flexible. Either model works, but you just want to make sure you're in a place where you'll be supported, especially if you're choosing to do a fellowship, where you'll be supported to pursue this work, and you're not going to end up, for example, spending your research year in someone's lab, because that's just what you do. You know, that's not like that doesn't make a lot of sense for someone who's interested in health policy. That is not going to strengthen your value proposition when you're asking for a leadership role in the future. And another question that I think people often bring to me is, well, you know, I'm actually interested in community practice. I'm actually interested in private practice, independent practice, joining a consolidated group. You know, do I have to be in academics for this work? And I'd argue, again, you know, the spoiler is that there's no right or wrong answer, but I'd argue that in a lot of places, doing this work in community practice is sometimes even easier to get support from, depending on where you are. So I say depending on where you are, because if you're in a group that is extremely productivity focused, then of course it's going to be harder to make a case to get an equal salary to someone who is doing, for example, you know, 10,000 RVUs a year. If you're only doing 5,000 RVUs a year, it's going to be difficult to make that argument. But there are certain practices that are recognizing in today's environment of how we pay for healthcare, it is really hard to survive. And so they need someone who's savvy in coding and reimbursement, who's savvy in negotiating contracts with payers. And so if you have an interest in that area, that would be a really unique fit for you to join a practice and perhaps be their lead person in some of those fields. So just keep your eyes out, or keep your eyes open for those types of opportunities, because it doesn't need to be at the Vanderbilt, the Penn, the Harvards of the world. There's value in this sort of engagement in all types of practices. Networking is so important. And I don't think I appreciated the value of looking outside of my specific department until later in my residency. And I've especially tried to lean into this during my time here at Vanderbilt. A lot of us are training or at medical school in, you know, places that are affiliated with amazing health policy, public policy, or law schools. And I think it's a really unique time for us to be able to cold email, perhaps, you know, the professor of whatever you're interested in the school outside of the health system that you work in. You should build those connections now. As I said earlier, although we have the doctorate and we have our, you know, clinical expertise to lean back on, there's a lot of things that we don't know. And don't be afraid to say, you know, I am not really an expert yet in this specific area. For me, I can give you an example. It was drug costs. I had a big interest in trying to figure out why Americans pay so much for their prescription drugs. But I was quick to recognize that this system didn't really make a lot of sense to me. And like, I was reading and I couldn't understand what a PBM was. I was just struggling with like, okay, wait, so what is a PBM? And then how does Medicare fit into this? Because Medicare is paid for by the taxpayers, but it looks like these Part D plans are actually private insurers. Like, I was stumped. And so I reached out to Stacy Ducensina, who's a professor of health policy at Vanderbilt. And I just had a call with her and we talked through some stuff, and she pointed me to some interesting resources where I was able to educate myself more on the ins and outs of how we pay for prescription drugs. And then from there, you know, built up the confidence to eventually do a study looking at this, demonstrating the value of Mark Cuban's cost plus drugs, and the rest is history. Like, before I knew it, I was emailing on the daily with Mark Cuban. He was visiting Vanderbilt. We were like live streaming an event where he's sitting right next to me. So my point is that networking, without that initial networking step of me recognizing that I had a deficit in my knowledge that I wanted to fill, I never would have been successful in any of the other subsequent steps. Twitter is an interesting place, or I should say X is an interesting place right now. And I think there's been a bit of a shift. I mean, those of us who are on it are still on it. I admittedly engage a little less on X now than I did in the past, but I've been looking at other ways to network with folks, particularly after starting my master's in business school. I realized that people are like all over LinkedIn for physicians. There's obviously Doximity. There's a bunch of other like Instagram threads, and I'm not on TikTok. For all you TikTokers out there, I know that there's ways to network on that app too. It just, there's a million ways to do this, whether it's social media, whether it's just emailing and old school formally like meeting people at your institution. Networking is just so, so important. And I actually think it's pivotal to create a name outside of your institution, because you never know where you're going to be. Today you're at one place, tomorrow you're at another. You want to create, you want to kind of brand yourself as somebody who's known for your expertise outside of just your specific institutional department. I think that's important. Everyone has heard of these three terms: mentor, sponsor, and advocate. And I'm not going to go into the differences between each of them, but they are all incredibly important in this health policy work. Again, I'll stress that you may need to look outside of your institution for mentors. For me, both my chair, Dr. Penson, and CJ Stimson, who I work with on the pop health side, both urologists. They were both at Vanderbilt while I was doing my residency at Penn, but they were both formative mentors for me throughout my residency, despite the fact that they were at another institution. I can name off so many other folks. Angie Smith has been a huge mentor and sponsor for me. And I've particularly leveraged SWU for that type of sponsorship and for advocates who will suggest my name for things when a health policy related topic comes up, or will invite me to give a talk to the residents, whatnot. That is how you build yourself as a subject matter expert. And so you will need people in all three buckets. For me, I was very lucky to train at Penn, where everyone was so supportive. And I had a bunch of sponsors and advocates, Alan Ween, Tom Guzzo, always looking out for me, always trying to put me up for opportunities. But would I say they were my health policy mentors? No. But did that matter? No, they may not have been my mentors in the health policy space, but they were mentors in other aspects, and they were still supportive. So not everyone's going to fit all three of these buckets. Some people may be your clinical mentor, but your health policy sponsor. Other people may be a health policy mentor and not really a sponsor or advocate. That's okay. Just recognize that, there's something to gain from everyone. And you can even look outside of medicine. In fact, I would encourage you to consider looking at non-physicians. So that was a whirlwind, but I'm going to try to just summarize it and reinforce the fact that in order to create, instead of a dual path, I'm going to name it a multidimensional career that incorporates health policy and advocacy into your first job. You need to be able to tell a story. You need to be able to take all of the work that you've done and use it for an elevator pitch that demonstrates your value proposition when you're interviewing for your first job and you're asking for a non-clinical role. And just a quick reminder, obviously everyone on this call knows this because you're all engaged in the PAR, but why? Why does it matter, right? Why not just take a job that's 100% clinical, follow the traditional route? Why not? And I would say that's great. We need fully clinical folks. We have a shortage of urologists, in fact, so it's really important that we fill those roles. But I just want to remind everyone that, we've really been missing the physician voice from a lot of the work that is done in healthcare delivery and how we provide care for our patients. And the reason for that is because we're not at the table. I think it's really important that we have people from diverse backgrounds, people from diverse educational backgrounds, people who are physicians, non-physicians, clinical, even outside of healthcare, all on, these decision-making bodies, because the way healthcare is headed right now, it's unsustainable. We can't afford it. We're not doing a good job. There are huge, disparities that we're finding the more and more we look. And we want to be able to provide the best possible care for Americans. So to do that, for those of you who are here and who are passionate about this work, continue to foster your interest in health policy. I am always happy to chat with anyone. We can put my email in the chat and you guys can reach out anytime. But, I just want to remind you that just because you're a urologist, that doesn't mean that you have more to bring to the table. And based on your clinical expertise and experience, I bet you all of your respective healthcare systems could really benefit from having, you in the room when a lot of these discussions are going on about big decisions. So, I think we have probably a little over 10 minutes left for discussion, for Q&A. And if anyone has any questions specifically on something I talked about or ideas that you have for all of your careers in the future, hit me with them. I'm happy to chat.
Thanks so much, Ruchi. Let's open it up to anybody who's got a question to build off of what Ruchi said or take things in a different direction. I think, Salim, you want to go?
Sure. Yeah. Hi, Dr. Talwar. Thank you so much for your talk. That was super helpful. I do have a quick question. How involved are you when it actually comes to the implementation of like the QI projects or any of the kind of interventions that you're suggesting?
Yeah, that's a great question. So for example, for the opioid project that I did in residency, it was me. I was the annoying person hounding everyone, stop ordering narcotics, So I think, but that was just one example. I think when it comes to QI implementation, depending on where you are, the kinds of resources that are available to you within your department or your institution, you may be able to lean on others. So you may be involved in the design aspect, maybe not as much in the implementation or measurement aspect, and that's totally fine. I think there's a way to build it in. If you want to take ownership, then I'm sure they would be more than happy to have you, run with it. But I think there's a way to tackle all sorts of roles.
All right, thank you.
While the rest of you guys are mustering up the strength to ask me some hard questions, I'll also add, I'm realizing there's one thing I didn't really touch on. Another way I was able to get support for some of the advocacy related work that I'm doing, so that's more volunteer-based work, really, with the AUA and, independently on my own, was that I leverage resident education into this. And I'm adding that now because I'm seeing all the faces of the Vandy residents on here. And, and it reminded me like, oh, I should talk about that. So one way to get support to be a leader in health policy is to be the educational leader in your department if you're not at an academic center that interfaces with residents. And so at Vandy, I'm working to build a health policy and healthcare delivery leadership track, very similar to the QI track that I did at Penn because I benefited so much from it. But this is not just quality improvement. We're really trying to arm our residents with the ability to take their capstone project in whatever direction they want, so that eventually when they are fellows trying to justify what they want to do with their research year, or if they're going into practice and interviewing for jobs, they're able to say, I graduated from a residency with a certificate in healthcare delivery. And so I have experience, and here's one more reason why you should hire me for this job. But at the same time, it gives me the support to go to the summit every year. It gives me the support to spend time on advocacy related activities that are not revenue generating. So just another thing to think about for those of you who are going to end up at places that have residents.
Ruchi, how much do you think the various projects that you've taken on, because like as you showed us, you've kind of taken a lot of different topics on, starting with kind of opioid, harm reduction in residency through to drug pricing and bundling now. And they're all kind of different topics. How much of those topics were something that you just independently had an interest about and pursued versus that was what you saw as like topical and needed, or someone kind of handed it to you? Because I get
great
a lot of hesitation from people getting involved in policy work because they're not sure what they want their issue to be.
Yeah, and that's a great point. And your issue will change. And a lot of those happen because people said, here's a problem we need to solve. You're an outside of the box thinker. Let's come up with a solution. So the opioid project, I had been thinking about opioid work and had conversations with one of our attendings independently on how we could address this. But it really came to be when one of the nurse practitioners told our chief of our division, everyone comes back after their prostatectomies with an entire bottle of pills, and I don't know what to do with them. There's no way for me to get rid of them. Let's come up with a way to fix this. So it was a problem I had been thinking about, but the reason that person came to me is because they said, I've heard you talk about this before. My nurse practitioner identified a problem. Can you be the point person to work with her and fix it? Similarly, bundles. I was really interested in value-based care, but I never, ever thought I'd be working in a healthcare system where I would be leading some of this work. And, I was thinking more Medicare, honestly. That's where I was more concerned about federal government spend. But this opportunity at Vanderbilt presented itself. And I was like, okay, I'm all in. It may not be exactly where I saw myself, but I have a ton I can learn and there's a ton I can bring to the table. So it's a mix. And again, when what you should be asking yourself is how does this contribute to my mission, vision, values? If you can answer that question affirmatively, then I think, you can get involved with that topic.
Thanks. Thank you. Nancy, did you have your hand up too?
Yes. Hi, Dr. Talwar. Thanks very much for this talk. I am a medical student on the PAR, and thinking about places to train, I wanted your thoughts on sort of like looking at places where there is already like strong support for policy advocacy work versus it sounds like a lot of what you've done also is sort of build the space out for yourself, even in your, finding your first job. So I guess, what are your thoughts on that? And also regarding the research year availability, because it seems like a lot of the work you were able to do was during that time.
Mm-hmm.
If you could speak more to that, I would appreciate it.
Yeah, of course. So during residency, I didn't have a dedicated research year. And I would say I was at a place where there was not a strong prior track record of health policy work. So it was, as you mentioned, creating a space. But you'll notice that I then came to Vanderbilt for fellowship and have stayed on in a place that does have a track record. And, I think no place is perfect. I can mush and gush about how much I love Vanderbilt, but no place is perfect, right? We have our issues too here. And so even if you end up at a program, because only so much is in your control for a match, even if you end up at a program where there perhaps is not as strong of a track record in engagement for health policy work, leverage resources like the PAR. Come to the summit and connect with other folks. Seek mentorship outside of your institution. It doesn't need to be where you're training. And make space and bring back the value to your program director and say, hey, I attended the summit. Can I present? No one wants extra work, but it may be valuable for you. Can I present to grand rounds and go through what we did at the summit? You'll educate others and potentially even inspire others to get involved, but also you'll show how you represented the department. So I think of course, ideally you'll find a program that has a research year where you can spend the year perhaps doing the AUA's Holt Group Fellowship. I had done that in the past. I spent some time in DC. But I couldn't do that during residency because I didn't have a research year. So it may not all be perfect, but I think that the really great thing is, Kara mentioned we were some of the first PAR members, and there used to be like 6 of us. And now I hear there's like 80 of you guys, which is so amazing. So leverage that community and know that you can collaborate with folks outside of your institutions and potentially even educate your own program as to, the value of this work.
Anybody has any last minute questions? We maybe have time for one more if there is one.
And thank you, Brad. I think you put my email in the chat. So definitely, guys, note down my email. Happy to chat anytime. Did someone come off mute? Maybe someone had a question.
Well, yeah, I've got one that is, I was sort of the natural succession to Nancy's question that, once you're exiting the training phase and looking for actual job positions, in your search, how many places had ideas sort of ready for you of programs and changes that they were looking to implement versus how many instances did you have to sort of pitch an entirely new program to them to be able to do this type of work?
Yeah, that's a great question. Vanderbilt was the only place that had it sort of carved out because, again, I had an established relationship here, and my mentor, it worked out for me in that my mentor was getting a leadership bump up, and so it created space where he had been prior. But I had been talking to other programs, won't name names, that didn't have quite as much of a vision, and in fact, would only be able to offer that 0.8 FTE model, which means 80% clinical work model. And I had tried to make a case for why, my time would be justified for the other 50%. And it was hard. It was hard. Not every place will fully value that, and that's okay. That's why you need to talk to multiple institutions. And it was really nice that I was able to turn to people for advice. So the beauty of urology is it's a small field, and there are people within outside of the institutions that I was considering who I was able to engage. There are leaders at other urology departments who have had faculty come in these hybrid roles. So, David Johnson is at UNC. He actually only engages in patient care once a week. And the other 4 days, he works for a value-based care startup here in Nashville. So that's one example of someone I had talked to. Kamal Gala is another urologist who spent some of his time at the VA in like Raleigh-Durham area. I forget exactly where, but it's affiliated with Duke. And the rest of his time, he's a medical director for, another value-based care company. So I engaged those people to help me strengthen my case. I would say, to more directly answer your question, you should at least have, when you're looking for a job, at least have 5 places at minimum that you're really trying to give this pitch to. Because, you want to make sure that you're giving yourself enough options. And if someone says, listen, we really can't support you beyond this 0.8 FTE, it's not like you put all your eggs in one basket.
All right, everyone. Well, I think if that's all the questions, we're right on time. So that's perfect. And I'll just say a big thank you to Dr. Talwar again for joining us tonight and for giving us a talk that I think we would say is both inspiring and also very practical. So that's much needed as a resident. You need both of those things. So thanks very much for that information. And I hope everyone can grab Ruchi's email and stay in touch.
Yeah, absolutely. Take care.
Are you or someone on your urology care team looking for practice management or coding and reimbursement education? If so, we invite you to check out AUA Coding Plus and the AUA Practice Management and Coding program on AUA University. Visit auau.auanet.org for more information and to register.